Mark Hayward, and I'm happy to be the organizer for the Population Research Center and CAPS One Collaborative Fridays. So it's really exciting. I have worked hard to bring you a diverse slate, outside speakers, running the gamut from topic, and it's really a diverse, I think, an exciting series this year. I hope you enjoy it. And I'm delighted to be able to have our first speaker here, Stacey. So I won't introduce Lawrence because Francisco is going to introduce Lawrence. But I wanted to welcome you all to the first of our Friday seminars. So welcome, and Francisco, it's up to you.
Yay, Friday seminar.
Hi, everybody. I'm excited to say a little bit about our speaker today. He's an assistant professor in sociology at Vanderbilt University, where he is a faculty affiliate at the LGBTQ Policy Lab and also the Center for Research on Inequality and Health. He uses a variety of methods, including survey data, experimental methods, and in-depth interviews to study gender, sexuality, families, and health. Please join me in welcoming Professor Stacey.
So much to Mark and Francisco for those warm introductions. I am so excited to be here, as I've mentioned to a few of you so far. This is my first time ever being in Texas, so I'm particularly thrilled to have Austin be my first ever visit to Texas and to be invited. And I'm excited to be presenting on what's been a really kind of engaging paper that has captured my attention in the past few months. Working on this paper at the end of May. Even though I had higher priority papers on my desk that I neglected to work on this paper, but productive procrastination, I guess, is better than unproductive procrastination. So the title of the talk today, I'm going to be talking about temporal and their use in health disparities between cisgender and transgender populations and the role of demographic change over the past decade. So before I begin, I do want to give a quick shout out and acknowledgement to my wonderful co-authors, Emma Marlowe. She is an undergraduate student at Vanderbilt University who has been really great in helping me think through the ideas and analyses, as well as Christina Powell, a PhD student at Princeton University, in addition to the institutional support I received from Vanderbilt, the Center, and the LGBTQ Policy Lab. So health disparities between cis and trans populations are marked and pronounced. We know from a relatively diverse body of work from sociologists, public health scholars, demographers, that there is such a thing as a trans health disadvantage. And this trans health disadvantage varies widely on a number of markers, including acute as well as chronic conditions, poor/fair self-rated health, depression and psychological distress, as well as a number of other things like health and exercise and other health behaviors. However, we know relatively little about temporal trends in health disparities between cis and trans people, how they've evolved decade, and in general, how the health of trans people has evolved over the past decade. And we argue in the paper that this is primarily due to two reasons, one of which is due to methodological recommendations and constraints, which I'll talk about, as well as data constraints. And before I begin, I do want to quickly acknowledge or define cis and trans people. So historically, cis has been used as a term to describe those whose gender aligns with their sex assigned at birth, whereas trans conversely describes those whose gender identity does not align with their sex assigned at birth. Of course, we can think all the ways about the ways such misalignment is itself representative of cis-normative thinking that posits, for instance, that people assigned male at birth are and should be men. But in general, I'll be kind of going through today's presentation. Yeah, can I show this? Producing valid and reliable estimates of health disparities across the gender spectrum have been no easy task. And this is in part because of probability-based sampling strategies with no LGBTQ oversampling that produces relatively small sample sizes of trans respondents. And so these small sample sizes make detecting disparities that are either small in magnitude or that aren't low in variance between cis and trans groups arduous, if not unfeasible at times. To construct healthy sample sizes, of trans people, scholars have pulled multiple waves or several years of data together and then adjusted for time-fixed effects, most notably here in their estimate. And this is a practice that has really been recommended by leaders in the field. It's been recommended by the Gender Identity and US Surveillance Group, and at this point has become really common practice in the study of trans health. And there are benefits and limitations to this solution. So in terms of what is gained, pooling data across multiple years can engender confidence in estimates. It helps us to minimize random and non-random error. But at the same time, it does come with some limitations. So for instance, it masks temporal variation in the health of cis and trans populations. It produces estimates of disparities, health disparities, net of and averaged across historical time. And it implicitly rests on an assumption of demographic continuity in cis and trans populations, when in actuality, the cis population, the trans population, there's reason to expect that they have evolved over time. So they might not be comparable in the same way that is assumed when we pool. Why is it that we would expect temporal variation in the health of trans people? Some reasons to expect a convergence of health disparities or a narrowing in health disparities between cis and trans people over time is due to a few different reasons, and I'll walk through each of these in turn. So one of which is the heightened visibility of trans people. The trans subject has really gained newfound visibility in the past couple of years, a visibility that trans historian Susan Stryker places around the mid-2010s, continuing in the following years. So when we're thinking about the 2010s, it ushered in these moments of heightened visibility. For instance, when Time magazine declared the transgender tipping point, cover of which was adorned by Laverne Cox. Caitlyn Jenner broke the internet, as one put it, covered Vanity Fair and asked the world to call her Caitlyn. A few years later, National Geographic pronounced that a gender revolution was underway, her story of which featured trans kids and trans youth. So the visibility of trans people could both reflect and contribute to a convergence of health disparities for cis and trans Americans if such visibility is accompanied by economic, social, and political gains, reduced discrimination, and perhaps even decreased internalized stigma, internalized transphobia. At the same time, we do have some evidence that shows increasing support for trans rights from 2015 to 2020. Confirming such attitudes among a nationally representative sample, a recent study found broad agreement in support of what they refer to as formal rights for transgender people. So for instance, about 3/4 of Americans believe that employers should not be allowed to discriminate against a transgender person, and more than 8 in 10 Americans, believe that a transgender person should not be denied the right to service at a restaurant. So when we juxtapose the findings from these more contemporary studies showing relatively liberal attitudes or tolerant attitudes towards trans people with the studies from yesteryear that showed really pernicious and negative attitudes towards trans people, we can think about evidence suggesting noteworthy changes in the attitudes towards trans persons over historical time. Attitudinal changes have also been accompanied by noteworthy, if limited, socio-legal advancements. So for instance, in the case of RG and GR, Harris Funeral Homes Incorporated versus the Equal Employment Opportunity Commission, decided on June 15th, 2020, the Supreme Court ruled that Title VII of the Civil Rights Act of 1964 extends employment discrimination protection to transgender people, equating discrimination against trans people to discrimination on the basis of sex. And I should say that with the Supreme Court case, this is generally, I think, lumped in with Bostock v. Clayton County, which was decided around the same time, or even within that same kind of realm when we think about employment discrimination. Although healthcare barriers remain significant for trans people, for instance, in the form of discrimination that they report and treatment denials at the doctor's office, recent evidence suggests that gender-affirming care has become more accessible over time. So one study using the national inpatient sample showed an upward trend in both the absolute number and proportion of patients with what is known as transsexualism or gender identity disorder diagnostic codes from 2000 to 2014. This same study showed a precipitous decline in the proportion of respondents who were classified as self-payers and a notable increase in those who were covered by Medicare or Medicaid. So if such trends continued in the present, the increasing availability and accessibility of gender-affirming care might signify a decline in barriers to healthcare for trans people. In past work on the links between, for instance, barriers to healthcare and negative healthcare experiences and health. These types of things might, for instance, be related to conversion. So for any of these four reasons, we could, for instance, expect that health disparities between cis and trans people have narrowed over time or have converged over time, leading to what we call the convergence hypothesis. In case of diverging disparities, why would we expect that the health of trans people have gotten worse relative to cis people, grown more wide over time? One really convincing reason, I think, is that in the past few years, we've really witnessed a skyrocketing increase in anti-trans legislation and anti-trans policies at the state level. So for instance, close to the start of the study period in 2015, only 21 anti-trans bills were proposed across the United States. Starting in 2020 and continuing in the following years, a dramatic explosion in anti-trans state legislation materialized, where a total of 615 anti-trans bills were approved in 2023, marking the fourth consecutive record-breaking year in terms of anti-trans state legislation. As the work of demographers and sociologists have shown, we should not underestimate the consequences of these state policies for population health and what this might tell us about health disparities over time. At the same time, we have some preliminary evidence suggesting that fatal violence against trans people is on the rise, which might matter for growing disparities between cis and trans people. So for instance, this figure shows findings from Laurel Westbrook's study in Gender and Society, where she put together an original data set, all known fatal victims of trans, all known trans victims of fatal violence. So as we can see from 2014 onward, there is a slight but upward trend in fatal violence against trans people. And my reading of more recent data, including, for instance, from the Human Rights Campaign, does not suggest a more optimistic take. So for instance, in 2021 marked the deadliest year on record for fatal violence against trans people since the Human Rights Campaign began tracking such data in 2013, when the end of the year list in 2021 culminated in a list of 47 trans victims of fatal violence. So this fatal violence against trans people might exacerbate, for instance, anticipated transphobia, anticipated violence, thereby undermining health. And moreover, when we think about the ways in which representations about and the overwhelming focus on violence that trans people might face, what some people have called an epidemic of violence against trans people, as Laurel Westbrook has argued, might lead to this kind of vulnerable subjectivity that infuses trans subjectivity. Of course, this is drawing on Foucauldian logic that argues that power is both repressive and productive as well. And then finally, we do have some empirical evidence that documents growing mental health disparities between cis and trans people. This study focused on a much narrower time period than we focus on in the present study, and only considered poor mental health days. But in general, we do have some preliminary evidence to suggest that disparities were growing over time. So for these three reasons, these lead us to the divergence hypothesis, which is that health disparities between cis and trans people have diverged between 2014 and 2023. When we think across the social sciences, when we think about the literature that has given us insight into why trans people face, for instance, or are more likely to report poor/fair self-rated health, or overrepresented among those who report suicide and ideation, minority stress theory has really become a principal explanation for the trans health disadvantage, rising to the level of paradigm in the study of LGBTQ health. Because of this theory, researchers have relied on experiences that are physical and proximal stressors, discrimination, violence, experiences of and expectations of rejection, for instance, to explain why trans people are overrepresented among those who are poor health. In this paper, we move away from thinking about minority stress theory to explain trans health inequality and instead bring a sociological and demographic lens to question whether demographic change in trans population over time might be an important factor. We do know from one study, this evidence is quite sparse in this regard about how compositional change has materialized over the past few years in the trans population. We know a little bit, for instance, about what might suggest rising or declining ages in the average age of the trans population. For instance, the study looks over time and finds that the most marked increases in trans identification are driven by 18 to 24-year-olds. For instance, this would portend declining ages in the composition of the trans group over time. And beyond these socio-demographic changes, for instance, there are reasons like some of those I outlined, whether it be attitudinal change, socio-legal change that might have given rise to changing socioeconomic and family profiles of the trans population. So departing from this prior research, suggests that demographic change in the trans population might be an overlooked, but potentially paramount factor underlying the health of trans people. And already do remain agnostic about how demographic change, for instance, might have contributed to temporal variation and health disparities by gender. Precedent for examining the role of demographic change among groups is strong. This is probably something that I don't have to convince demographers or those in the Population Research Center of, but I think is important. So given this leads to our three research questions. The first of which is how have health disparities between cis and trans populations evolved over time? Second of which is how has the trans population changed compositionally? Our third research question is what might the health of the trans population look like in 2023 if the trans population had not changed demographically as they had since 2014? So in the way of methods, so we use Burfus data, behavioral risk factor surveillance system data that are Centers for Disease Control and Prevention product. These are population level data with a probability-based sampling frame. And the Burfus included an optional sexual orientation and gender identity module in 2014. Some of which I've outlined are the key kind of advantages using these data and allowing us to look at temporal variation over time. In this case, our independent variables are, in this case, independent variable is gender. We use a gender modality indicator, and I'm happy to talk more in the Q&A about what that means. But essentially, we are distinguishing in this case with a binary indicator between cis and trans people based on a measure in the sexual orientation and gender identity module. We look at variation over time using the year of the interview. And then we use 4 different outcomes, 4/FAIR self-rated health, 4 physical health days, 4 mental health days, both of which were asked in the past 30 days, how many days of your health were poor, whether it be mental or physical health. And then finally, whether the respondent reports ever having been diagnosed with depression by a medical professional. So we first estimate regression models predicting our 4 outcomes as a function of gender modality, year fixed effects, and an interaction between our gender modality indicator and our year fixed effects. And in what follows, we show predicted probabilities or predicted means from unadjusted regression models. We then we show descriptively compositional change over time in the trans population for our covariates. Finally, we conducted what are called Awaka blinder decomposition models. We estimated 3-fold decomposition models in this case to decompose change in poor mental health days and diagnosed depression. These were 2 outcomes. To give a spoiler, where we did witness the divergence in these outcomes. So we decomposed change over time in the trans population for those 2 outcomes. We listed the covariates up here: age, sex, sexual identity, race, and region. For SES, we use employment, education, and annual household income. And we include marital status and number of residential children. And to use decomposition parlance, we composed change into endowments effect, endowments effects, coefficients effects, and then the interaction effects between endowments and coefficients effects. I should say that we are primarily interested in endowment effects. So for instance, what is the association between the changing age composition of the trans population and their worsening mental health, and not necessarily interested in what are known as coefficients effects, or for instance, how has the relationship between race and mental health changed over time for the trans population. So we pay particular attention to endowment effects, and that is what we present. And I will get to this point as I present the decomposition results, but they're expressed from the viewpoint of Group B and Group A. 2014 trans people are the reference category. Okay, so to get into the results, when it came to converging or diverging disparities, in this case, just to orient you all before we kind of walk through the next couple of pages, this shows the predicted probabilities of poor/fair self-rated health, distinguishing between cis and trans people, showing over time from 2014 to 2023. I'd be interested to know what you all think about this figure, but in general, I think we see fairly stagnant trends, at least throughout most of the study period, even though, for instance, the health of the trans population is characterized by a higher predicted probability of reporting poor/fair self-rated health across much of the distribution. But starting in 2021 and continuing in the following years, we do witness what one could, I think, reasonably argue is some type of divergence. And we can think about that as we go through today's talk. We're thinking about predicted numbers of poor physical health days. The results are generally in line with what we find when we look at predicted probabilities of poor/fair self-rated health. So for instance, cis people in 2014 reported about 3.8 poor physical health days relative to trans people reporting about 6.7 poor physical health days. And these trends generally remain somewhat stagnant over time. We don't find evidence that they have grown, for instance, dramatically wider, dramatically diverged over the study period. In sharp contrast to the fairly stagnant trends in predicted probabilities of poor/fair self-rated health, and the numbers of poor physical health days for cis and trans people, this figure does show a dramatic divergence in poor mental health days between cis and trans populations. So at the start of the study period in 2014, the disparity that separated cis and trans people is relatively small. Although the numbers of poor mental health days have risen for both cis and trans people over the study period, the divergence that we observe is largely attributable to the deteriorating mental health of trans people. So in fact, as we can see, trans people generally reported steadily and increasing numbers of poor mental health days in the past 30 days across the past decade. By 2023, trans people reported an average of 12.7 mental health days. This is a really stark disparity compared to cis people, averaged only 4.9 mental health days in the past 30 days, the same exact year. Now, according to the CDC and the National Institutes of Health definition, 14 or more poor mental health days is characterized as frequent mental distress and is consistent with diagnostic criteria for major depressive disorder. So taking such standards and applying them to this figure, you can see that the average trans person in 2023 just nearly met the threshold for frequent mental distress, reporting on average 12.7, 12.8 poor mental health days. As we witnessed a divergence in the poor mental health days between cis and trans people, we sought to examine heterogeneity across these key categories of difference. So for instance, we look across age, sex, gender, sexual identity, race, ethnicity, educational attainment, and then finally, annual household income. I do want to take a quick moment to say that these figures are showing average marginal effects for trans people compared to cis people across the study period. So for instance, if we just look at sex/gender for a moment, and you can see that trans people who are assigned male at birth, for instance, are reporting about 7 greater poor mental health days relative to cis people who are assigned male at birth. Okay. when we take the figure or take these kind of 6 figures together to look at heterogeneity, we do find in general that this is somewhat of a universally true story of diverging mental health across these key categories, at least when it comes to sex and gender, race, ethnicity, educational attainment, and then annual household income. When it comes to age, since I am talking to the Center for Aging and Population Sciences, I promised I would bring age in. We do see convergence here. So when we're thinking about trans people who are reporting increasingly greater days of poor mental health days in the past month, this finding is particularly true or is driven by trans people who are under the age of 40. Trans people who are under the age of 40 are really driving this divergence that we witnessed. This general finding right here, for instance, is obscuring a major pattern by age. You think generally about why this is the case, for instance, but a lot of literature I've been reading has been talking about the ways in which sexual minority or minority stress, for instance, although we move away from that in this paper a little bit, is concentrated or cruelly front-loaded, as some scholars have put it, right? So for instance, concentrated time in families of origin early on in the life course might partially explain why younger trans people have diverged over this time and are increasingly reporting greater numbers of poor health. When we look at the predicted probabilities of diagnosed depression, the depression diagnosis findings are actually even starker in some ways. So if we were to look at the start of the study period in 2014, for instance, we see near parity in rates of diagnosed depression between cis and trans people. They were about equally likely. These confidence intervals are overlapping. Fast forward to 2023, and greater than 60% of trans people, or the probability, I should say, of a diagnosed or depression diagnosis is greater than 60% trans people in 2023. Whereas the line, cis people, has increased a little bit, but remained largely the same. We do see evidence on both of these mental health factors that there has been a divergence in mental health for cis and trans people. Generally, when we look at heterogeneity for diagnosed depression across these select characteristics, we generally find the same story. So in this case, for instance, maybe particularly young and trans people under the age of 40 who diagnose or depression diagnoses are responsible in part for this divergence that we've witnessed documented here. Okay. So thinking broadly about compositional change over time in the trans population, we show results across all of these characteristics, some of which I'll point out I think are more important or more interesting than others, but I included them for us to look at and which we can flip through, I think, relatively. So for instance, over time, we have witnessed declining average ages of the trans population over time. It started out around 54 and is now hovering close to 38, 39. So on average, trans people are becoming younger as a population. This, of course, can lead to relatively pronounced increases in identifying as trans people among younger people. Percent female for trans people stayed fairly consistent over time. One of the most dramatic increases that I think is really important is that the percentage of trans people who identify as non-heterosexual in the versus lesbian, gay, bisexual, or something else has increased really markedly across the study period. At the start of the study period, about 13% of trans people identified as non-heterosexual. In 2023, about 70% of trans people are identifying as non-heterosexual. The percent non-white has changed a little bit, and I will say this obscures a little bit of kind of variation in the other racial categories that are not captured when we're dichotomizing race, ethnicity. In general, we've seen more pronounced increases in trans identification among Asian and among Latinx populations, and we have among Black populations, even as this has remained fairly consistent, percent non-white. When it comes to college education, I think we do find some convincing evidence that they've become less disadvantaged over time. the proportion or the percentage experiencing or reporting a college education, for instance, has just about doubled over the study period. Employment has decreased, which might also reflect variation in the average ages of trans people. Income increased a little bit, interestingly. And then finally, the percent married has fallen quite precipitously as well. Average number of co-residential children has remained similar, stagnant over the study period. So when we think about the compositional change that the trans population has undergone in the past decade, there are a few kind of key takeaways that I think are really important and that matter a lot for the decomposition, which I'll present momentarily. One of which is that the trans population has become considerably younger on average. They become disproportionately non-heterosexual. They become less disadvantaged on key markers of SES, most notably college education and annual household income, and increasingly or disproportionately not married. The study here. Okay, so getting to the results for the Awaka blinder decompositions, when I was showing my demographer friend these slides the other day, he made a joke that Blinder and Awaka never consented to have their names in front of a trans flag, which I thought was really quite funny. So getting into the results for the decompositions. So first, we decomposed the change in poor mental health days from 2014 to 2023 for trans people. So this is just for trans people, I want to point out. Up here, the 2014 predicted value is about 5.5 poor mental health days in 2014. The 2023 predicted value has risen to about 12.8 poor mental health days. These findings are exactly the findings that I presented in the unadjusted models, which jive perfectly with those. So the difference to be explained is about 7.3 poor mental health days. So in showing the endowments effect on the slide from the Awaka blinder decompositions, this number, the endowments effect, negative 5.54, represents the mean decrease in poor mental health days in 2023. The 2023 trans population had the same demographic characteristics as they had in 2014. So instead of, for instance, in minority stress theory, thinking about individual level causal factors that might explain why trans people, we instead are thinking about demographic change in the trans population as being really important. This explains about 76% of the difference, so it's quite large. And in particular, there are a few things that I want to highlight, one of which relates to the changing age composition, for instance, of the trans population as mattering for rising mental health inequality or rising numbers of poor mental health days. Non-heterosexual, the fact that the trans population has become disproportionately non-heterosexual over the study period matters quite a bit. And then of course, we can think about college education and marital status as well. These Awaka blinder decomposition results are from a model where we fitted a logistic regression model since we're predicting the probability of a diagnosis or a depression diagnosis. Comparing 2014 trans people to 2023 trans people. Walking you through the results on the slide, we can see that the predicted probability is about 21% for trans people in 2014, whereas it's over 60% for trans people in 2023. So the difference to be explained is right here. And as we can see, the endowments effect, negative 0.24, represents the mean decrease in poor mental health days. Again, if the 2023 trans population had not changed demographically as they have since 2014. Should say all else equal as well, which is really important in the thought experiment that is decomposition. Comes to diagnose depression, for instance, we also see changing age composition, well as the fact that the trans population has become disproportionately non-heterosexual, playing an important role here as well. With this paper, we think we make three kind of key contributions to the literature. One of which is that we provide empirical evidence of a divergence in mental health between cis and trans people. To our knowledge, this is the most extensive evidence to date across the largest period of historical time, showing how health disparities have diverged or remained stagnant between cis and trans people from 2014 to 2023. In this, we do show evidence that even though, for instance, disparities in poor/fair self-rated health and poor physical health days have not diverged, they have not converged as well. They have remained relatively stagnant, or as we've seen, especially in the case of poor/fair self-rated health, we might be witnessing a divergence in the last couple of years, which will be interesting to explore if it continues as more Burfus data becomes available. Of course, with this, these findings obscure a striking age pattern. So it is particularly young trans people who appear to be responsible for rising mental health inequality between cis and trans people. So we need to think more about the mechanisms that might explain this finding, whatever those mechanisms are. In addition to thinking about the temporal variation in the health profiles of cis and trans people, we really provide the most comprehensive evidence to date on how the trans population has changed compositionally over the past decade, with findings pointing, for instance, to the declining average ages, the fact that trans population has become disproportionately sexual minorities, increasingly a population characterized by double disadvantage or multiple disadvantage, as it might be the case, even as they have become less disadvantaged as it comes to some key markers of socioeconomic status. And in this case, demographic change, we argue, in the trans population has been a relatively overlooked, might be an important factor in rising cis trans health inequality. It might be key to helping us make sense of why we've witnessed such a stark divergence in poor mental health days and the probability of diagnosed depression over the past decade. With that, I want to say thank you so much. I look forward to your questions.
As is our tradition, the graduate student, the faculty may not ask questions until graduate students ask 2 questions. So are there questions from the graduate students? Thank you so much. You were great.
Yeah, please. And if people wouldn't mind saying their name, I'd appreciate that.
Yeah, my name's Hayes.
Please.
Yeah, I have 3 questions. First was how big was the sample size? Second, do you think life expectancy, like changes in life expectancy, given like rates of violence, have anything to do with the age trends?
Okay, yeah.
And then third, oh gosh. Oh, it's gonna haunt me. Give me a second.
Yeah, that's fine. How about I tackle the first 2, and then if the third one pops into your head, you can ask it. Yeah, so this is a great thing. I know I should have put more descriptive information. So I do, I have an appendix here. I will pull through all these slides. This is very small. I'm sorry, this table is very ugly, but it shows sample sizes, and I can read these across for trans people. So for instance, 518 trans people were captured in 2014. In the analytic sample, the entire sample is a little bit larger, but these people were missing on key covariates, all the way to about 1,200 people in 2023. So, yeah, at least 500 people in each year. And then increasingly, we've witnessed increasing numbers of trans people. Part of that, of course, is due to greater state inclusion of the sexual orientation and gender identity module. In later years of the Burfus, it was a lot more limited in 2014, 2015. So that is of trans people. Cis people, I mean, in total, so the total sample size is 1,692,417. So trans people are about 0.5% of the analytic sample in total. The second, Hayes, right?
Yes.
The second section is about life expectancy and age. Yeah, absolutely right. So when we're thinking about, the changing age composition of the trans population, as I navigate to this. Yeah, you're absolutely right. So there's a really great article in Demography by Landon Hughes, I believe, and colleagues looking at differential mortality using private insurance data to figure out differential mortality between cis and trans people, or what they call trans and non-trans people, identifying those as people who have received some type of diagnostic code related to gender identity. And yes, I think you're exactly right. So some of this might be, early mortality. So the finding did show pretty stark mortality differentials, especially in later ages. So some of these, the declining average age of the trans population is maybe in part driven by early mortality of trans people. So yeah, this is great. Did you think of the third question?
did.
Great, okay.
What do you think the role of social media plays in like differences in age as well?
Differences in age?
As in like younger populations tend to have more access to social media,
Sure.
mental health.
Yeah, absolutely. Yeah, this is a really good thing. I have some colleagues from graduate school who initially started doing a project on like TikTok and trans identification. I think social media is probably important, right, for exposing people to I don't know, ideologies, things. I mean, even the possibility of what it means for someone whose gender identity or feels like their gender identity doesn't align with their sex at birth might be exposed to more resources for those who are, connected to the internet, for those who are on social media. Especially as we think about the ways in which the visibility of the trans population has coincided with the kind of, recent rise in the social media age. So yeah, I think this is important. Sorry, I don't have a really well-formed, articulated response to that, but I do think social media probably plays some type of role. It's important to think about.
Thank you.
Thank you very much. Yeah.
My name's Cameron. I had a question about the trans population that you were looking at. It might depend upon the data set that you use, but because the trans identity isn't a monolith and that in and of itself can, be represented in so many different ways. Did you find differences in between folks that maybe are socially transitioning versus medically transitioning or somewhere in between? I'm curious what that looked like.
Yeah, this is such a great question. The CDC's birthday data are so limited. So the only measure that I use to identify trans people is coming from this one measure. I'll pull up here, which is, do you consider yourself to be transgender? If the respondent replied affirmatively, they were then asked, do you consider yourself to be female to male, male to female, or gender nonconforming with this information for interviewer notes? So I don't have information on, for instance, to what extent these people are out, to what extent they conceal their identity, to what extent they pass. I don't have, the birth list is quite limited in that information. I think if you're interested in this, or we could think more, the US Transgender Survey, which I've turned to using 2015 USTS data, include a plethora of information. So even though it's not, the sample is not from a probability-based framework, I do think those data provide a really interesting insights into relationships between average age of coming out, identity concealment, to what extent people are out socially in the workplace, at other places, and how those things might matter for health. So that's a really great question. With the purpose data,
Thank you.
Yeah, thanks, Cameron.
Hi, my name is Annie.
Hi, Annie.
My question is kind of similar to Cameron's in that, obviously, trans identity is not just a binary variable where there's so much fluidity. Do you see I guess kind of building off of his question, do you see a way where, one, because younger age seems to be this very kind of relevant, or younger age of the trans population seems pretty relevant in this study. Do you think that has anything to do with, you're talking about cultural acceptance of trans people and perhaps people coming out? I know that's a very kind of loaded term, potentially younger, or kind of feeling more comfortable with their identity earlier on. Do you think that has anything to do with the result of this study? And also, do you see a way that you could quantitatively measure those kind of aspects of trans identity?
That's a good question. I haven't given a ton of thought as to whether we'd be able to gain leverage on that. I borrowing kind of insights from, some older research, thinking through who was captured, for instance, in surveys. identify sexual minorities, right? I mean, some people have argued, like Elon Meyer, that they represent a select group and that these people, for instance, who are identifying as sexual minorities are generally probably more comfortable with their sexual identity, their non-heterosexuality, and therefore might have better health as a result. So yeah, you know, I don't know if I could gain leverage on that with the BRFIS in any way. But related to both of those questions, and I'm sorry if I skipped this, Cameron, but thinking about you had mentioned that trans, you know, is not necessarily this binary variable where people are or not trans. Yes, this is great. So, and I want to kind of jump to that here, looking at findings that are split up or disaggregated by gender identity. So, although, you know, small sample sizes, you know, make it difficult to include this as a main component of the analysis, but I think it's really helpful as a supplement. And for instance, we do find that in the case of both poor mental health days and diagnosed depression, that there has been a divergence for all of these trans people. So thinking about, for instance, trans men up here, top right quadrant, trans women, top left quadrant, and then gender nonconforming trans people in the bottom right quadrant. We do see in general the diverging trends that align with what I presented in the main paper. And I should say here as well that this 0 line represents cis people. So relative to cis people, gender nonconforming people, for instance, are reporting about 9 greater poor mental health days. See the same thing with diagnosed depression. Although, as you know, I will also mention that these do, it looks like, for instance, gender nonconforming people in both cases are reporting particularly greater poor mental health days, diagnosed depression. So, you know, you both are right in thinking about the limits of specializing trans or gender modality as we have with this binary indicator. And yeah, that there are all these other features that matter and biographical experiences that we capture. Those are really important. Thank you both. Hi, Christy.
So go back to your, please, go back to your gender modality question.
Yes, please.
So something I was thinking about with this question is, I know that not all states were included this item. So I wonder if you can tell us what the coverage is like in terms of the number of states that participated. And I also started to think about state level policy and just differences in political environments with this. But you know, you had that figure up about like the anti-trans bills, and a lot of that happens at the state level. And so I'm not trying to give you another project, but I'm interested in like, you know, coverage of like what states are not asking this question.
Yeah.
And then if you thought about like state level political environment as an important.
One of the chapters of my dissertation was all about anti-trans state policy using data from the BRFIS and the Human Rights Campaign, the Movement Advancement Project, thinking through some of those questions. So I will say across from 2014 to 2023, 46 states asked, at least at one point in time, included the sexual orientation and gender identity module. So this is even worse table to have on the side, but Alabama as an appendix. Yeah, so Alabama included it in 2023. That we see. But for instance, these states appear. So for instance, Maine, Nebraska, New Hampshire, 45 states, excuse me, Oregon, and then South Dakota were the 5 states that I think vary to no small degree, right? In this. So, you know, as people began turning to the sexual orientation and gender identity module in the BRFIS a few years ago, a lot of concerns were raised about, you know, are we capturing a select group of people? Is it only the most liberal states that are including this measure? Is it only the most conservative states in an effort to surveil or track, you know, the extent to which their population is LGBTQ? So that's generally not the case, but you know, we have thought through kind of some ways to deal with this, the differential inclusion of the sexual orientation and gender identity module across time for states. And so this figure, for instance, shows just the 5 states that included it in every single year from 2014 to 2023. So I forget what they're Ohio, my home state, is one of them. New York, Hawaii, Minnesota, some other state are the 5 states that included it. So in this sense, this also gives us kind of confidence in our findings that we are witnessing this divergence among a representative sample from those 5 states where we are seeing this divergence in poor mental health, and the findings for poor/very self-rated health and poor physical health days generally are consistent as well. So if you have any other ideas for how to gain leverage on the differential inclusion of the SOGI module, but this is what we've come up with so far. It's a great question.
Do you control for cell phone versus landline? Because that has something to do with the missing data.
So yes, yeah, so we did. So, well, okay, so first of all, when we're presenting these main figures, these are unadjusted results. So these are really just looking at, including gender identity, the year fixed effects, and then the interaction between the two. I haven't included it here, but we do run supplemental models where we do control for our key list of covariates. And yeah, so in that case, we do adjust for whether or not they took the survey or they were contacted on a landline versus cellular phone. I will say some of these effects are attenuated. So, the gap or the divergence in poor mental health days and diagnosed depression are generally not as stark when we adjust for those sociodemographic differences, when we adjust for SES and family characteristics, but they are still present. So, those individual level characteristics, one's employment, for instance, aren't fully absorbing or accounting for that association. Yeah, the landline thing is great. Thank you.
Good answer.
Hey, my name's Nicole. I was curious, I noticed a lot of the divergence you were tracking was becoming really obvious post 2020.
Yeah.
And I know COVID kind of inflamed a lot of the health disparities you were already kind of grappling with, and I was just curious if you think COVID had a part in those trends getting even worse, or if you expect it to already continue on that.
Yeah, so right in this thought experiment, you're asking if COVID never happened, if the pandemic never materialized, do you think we'd still witness this kind of divergence?
Yeah.
To the extent that I'll go back to French for mental health days. To the extent that these trends were already, up to 2020, for instance, before the onset of the pandemic, we're already witnessing fairly pronounced, divergence. Part of me thinks that they would continue. That isn't to say that the pandemic probably didn't play some important role. I know recently, Randy Manning, Claire Camp-Dush, in their National Couples Health and Time Use study have increasingly looked at the effects or kind of associations between the pandemic and have found in many cases, more pronounced associations in health outcomes of pandemic life in general and stress from the pandemic. So to the extent that might have exacerbated the health of trans people, maybe more relative to cis people, is possible. There are probably ways we could do some type of difference analysis where we look at the effects of the pandemic to try and gain leverage on that. That's a great question. Deb.
So, I don't know a lot about this, even though I should. How does probability of depression change over the life course? Are younger people more prone to depression than older people? And so I was just wondering if that's.
Yeah. Yes, this is a good question. So my understanding from preliminary data, in addition to looking at temporal variation in health, we're starting to look at variation across the life course with these cross-sectional data. So at least in terms of the BRFIS, my understanding is yes, that, for both cis and trans people, that the probability, for instance, of diagnosed depression is greater, earlier on in the life course relative to later, because these are repeated cross-sectional data. We don't observe people over time. And so part of it could be due to I don't know, I was going to say I'm not an aging scholar, but thinking about cohort period effects and whatnot. So this is a good question. Do you have thoughts about?
Well, I'm just thinking that the trans population has on average grown younger over time, but the cis population has not.
Yes.
And that's all. That's my only observation.
Absolutely. Yeah, no, I think that's really important. I think one way that we could deal with that is, the decompositions are somewhat getting at that, thinking about as far as trans people, but we have not conducted comparable decompositions on the cis population. So in the case of poor mental health days, it'd be important to think about in relation to cis people. And on that subject, just really quick, I will say that we didn't present it here, but we also, in general, even though we aren't finding these large differences for poor/fair self-rated health, for poor physical health days, part of the reason is in fact that we are witnessing growing physical health inequality because the trans population has become considerably younger on average. So that is playing an important role. It's just that there's not as much of a divergence or difference to decompose. Yes.
Hi.
Right.
Yes,
Great,
Courtney. Thank you for a great talk, Florence. So I'm curious, given this divergence that you found, of your thoughts on interventions of how we can address the, disparities in potentially poor health in this transgender population. And I'm thinking about that given the transgender population's hesitancy to potentially use traditional medical services and engage with the medical industrial complex.
Yeah, I think that this is such an important question. I think as far as interventions go, no, I haven't thought too much about kind of interventions. In some other work, I've been thinking a lot about the ways in which negative healthcare experiences, so being denied treatment or facing transphobia in the doctor's office, or healthcare barriers like lack of insurance, lack of the ability to find a provider who has trans knowledge, those kinds of things, stratify health and suicidal ideation. So yeah, I think you're right, Courtney, in thinking about, the medical institution as having what some scholars have called this outsized influence over the lives of trans people for a number of reasons. But intervention wise, no, I haven't thought too much about it. So I don't have a really compelling answer to that. I think a really pessimistic person could look at this and say, well, it's their fault. They became more queer over the study period. And so, thinking through how to deal with that and talk about that. So I'm sorry I don't have a compelling answer, but this is important.
I just want to add one little thought that I had a scary thought. Kind of related to that, like,
Yeah.
how would, certain groups of people interpret these results? Like, oh, becoming trans is making young people more mentally ill. Like,
Sure, yeah.
it's sort of a
Yes,
tricky area.
it is. It is a very tricky area to reside in and to do this work in, especially in this kind of sort of current socio-political environment. So yeah, I mean, this is something that we're thinking about. I mean, the way we've thought about it so far is instead of turning the attention on trans people, how they have changed compositionally. I mean, one other type of way is to alleviating, for instance, the mechanisms that produce sexual minority disadvantage would appear to make strides in reducing the trans health disadvantage as well. So, flipping the script a little bit, that could be one way to think about that. That said, I mean, conservative with bad intentions are not, going to take that. But so yeah, this is tricky, and I think we're going to try and be exceedingly clear and careful as we do
Policy
that.
context work backs up that it's their fault.
Yes.
Policy makers, not.
Yeah,
They should.
absolutely.
We have time for a half a question.
Have a question.
Yeah, great.
So I was actually on lines with Christy thinking.
Yeah. Okay.
And where people want to work.
Okay.
So I just wonder if there's some way of thinking about, you started with visibility in state policy, right? It's like you're thinking about like people who were already in states that didn't pass those.
Yeah.
Their visibility was actually positive for them.
Sure.
There's the people in state like Texas, and I know this fact in Austin, a lot of my trans friends have actually left Texas after these things, going to states where they don't want those.
Yes.
Which might kind of obscure some of even the geographic
For sure.
variation. And I was just wondering how you, what your thoughts were.
Oh yeah, this is such a good question. I dealt with this a lot thinking through papers on doing policy in particular. I think so, the Berkfest has very limited data on like geographic mobility to residential history. So I can't, in the survey data, identify how long people have been. I do think, we are currently witnessing trans people, the most privileged among the trans people fleeing those really regressive socio-political climates, like maybe in Texas or Tennessee. So yeah, and that matters, right? For estimating these health disparities. So I'm happy to chat more about that.
Especially when the numbers are small.
Yes, absolutely. Yeah.
That migration can have a big effect.
Matters, yeah, for sure.
Please, I'm sorry, but we've run out of time. It's kind of fun to run out of time when we're having such a lively conversation. But please join me in thanking Lawrence for a great talk.